I want you to imagine um, a medical condition that's just so pervasive and honestly so severe that it strikes 49 million people a year globally.
Yeah, that number is, I mean, it's almost hard to wrap your head around,
Well,
honestly.
and of those 49 million, it actually claims 13 million lives. I mean, just to put that into perspective for you, that is more than many major global diseases combined.
Absolutely. And, when we think of sudden, terrifying medical emergencies, we almost always picture like heart attacks or strokes.
Where there's a specific, like a localized blockage or something.
Exactly. A specific blood vessel is blocked. But sepsis is completely systemic. It is your entire body, basically, turning into a battlefield.
Hmm.
And the collateral damage from that crossfire is what causes the kidneys, the lungs, and the liver to ultimately shut down.
And because it's so deadly and involves literally every system in the body, the rules of engagement for doctors are constantly evolving. So that is the mission of our deep dive today. We are taking a massive stack of sources, specifically the brand new Surviving Sepsis Campaign 2026 guidelines, and we're acting as your translators.
Which is quite the task, given how dense these guidelines are.
Oh, totally. I mean, this document was authored by 69 experts from 23 different countries. It represents the absolute cutting edge of critical care medicine, and we are going to distill this highly technical medical playbook into the most actionable insights about how the front lines of medicine are changing. And here's where it gets really interesting. These new 2026 guidelines completely flip some of the oldest, most entrenched medical dogmas right on their head.
They absolutely do. But I think it's important to ground ourselves in what this document actually is, because these guidelines aren't just, arbitrary rules made up by a committee in some boardroom.
Right, it's not just guesswork.
Exactly. They are a rigorous synthesis of global clinical data. What we are seeing in this 2026 update is a massive, deliberate shift toward precision and speed in really high-stakes environments.
Which makes sense, but spotting sepsis seems like the hardest part, right? Before doctors can even treat it, they have to realize it's actually happening.
That is the ultimate challenge.
Yeah.
Because sepsis mimics so many other common conditions.
Yeah, reading through the sources, it's like you could just look really tired or be slightly confused or have a fever. So the guidelines are radically overhauling how early recognition works. They're strongly recommending that hospitals use what they call code sepsis or sepsis huddle protocols.
Yes, the huddles.
Okay, let's unpack this for a second because a code sepsis sounds a lot like a Formula One pit crew to me.
That is actually the perfect visual analogy.
Right.
Because if you've ever been in a typical emergency room, you know it can be, well, a bit chaotic.
Yeah, understatement of the year.
Right. A single nurse might be juggling 3 or 4 different patients. But when that code sepsis is called overhead, the dynamic instantly changes to this highly structured swarm.
Like a pre-assigned multidisciplinary team.
Exactly. You get a pharmacist, a dedicated nurse, a physician, a respiratory therapist. They all drop what they're doing and converge at the bedside. And they have standard operating procedures ready to execute the literal second they arrive.
So one person's drawing blood, another is spiking IV bags, another is checking the airway.
Yes. Everyone knows their specific job.
And what's wild is that the sources highlight this choreography doesn't even start in the hospital anymore. The guidelines are actually pushing this out to the ambulances. Like, if paramedics are transporting a patient and the drive time to the hospital is over 60 minutes, they are now encouraged to screen for sepsis right there in the back of the rig.
Catching it before they even roll through the hospital doors is critical. Because every single minute the body remains in a state of septic shock, the tissues are starving for oxygen.
Wow. So by shifting it to the pre-hospital setting,
The ambulance crew alerts the hospital in advance, that PIC crew we just talked about. They can literally have the IV fluids hung and the antibiotics drawn up into syringes before the ambulance doors even open.
that is incredible. I was also reading through the sources, and they mention a major shift in the actual tools they use to screen people. Because for years, a tool called the QSOFA score was heavily used, but the 2026 guidelines seem to be completely breaking up with it.
They are. The QS-SOFI is out as a single screening tool.
Yeah, and instead they're pushing these other acronyms like new Ws, new Ws, or SIRS. So what are these and why the sudden change?
Well, it comes down to a classic tension in medicine, which is sensitivity versus specificity. The QS-OFA score was a very short checklist. It looked at blood pressure, breathing, and confusion.
Just those three things.
Yeah. So it was highly specific, meaning it was very good at telling you if someone was already incredibly sick and, frankly, at high risk of dying. But it completely lacked sensitivity.
meaning it missed the subtle cases.
Exactly. It missed a lot of patients who were in the early, subtle stages of sepsis. It was essentially waiting for the patient to fall off the cliff before sounding the alarm.
Right, and you want to catch them before they fall. Okay, so what do the new tools do differently?
So tools like NUWS, which stands for the National Early Warning Score, look at a much broader range of vital sign deviations. They track subtle shifts in body temperature, heart rate, oxygen saturation, and respiratory rate over time.
Ah, so you see the trend.
Yes, it allows clinicians to catch the deterioration while the patient is still, walking near the edge of the cliff, so to speak.
That makes total sense. But naturally, when we talk about tracking complex data and predicting deterioration, my mind immediately goes to the future. I'm thinking, surely we have an app for this now.
You'd think so, right?
Right. There are all these shiny new AI prediction models hitting the market and these mRNA host response diagnostics that, like, look at your cellular genetics in real time. But the guidelines explicitly state there is insufficient evidence to recommend any of them yet. Why the hesitation?
Because in a global health crisis, proven, universally adaptable systems save vastly more lives than unproven, really expensive technology.
Okay, that's fair.
I mean, the AI tools and mRNA diagnostics are scientifically brilliant, sure, in a laboratory setting,
Yeah.
but they do not yet have the rigorous, large-scale clinical trial data proving they actually improve patient survival in the real world compared to a well-trained human pit crew using standard vital signs.
Ah, so it's really about what works everywhere, not just in some fancy tech hub.
Precisely. These guidelines are written for the globe. A complex $50,000 AI prediction tool might work in a highly funded research hospital in Boston, but it does absolutely nothing for a small clinic in a resource-limited setting.
Right.
Good old-fashioned vital signs, blood pressure, heart rate, temperature can be measured reliably anywhere in the world.
Okay, so the alarm is ringing, the pit crew is assembled at the bedside, the vital signs are screaming sepsis. Knowing a patient is walking off a cliff doesn't stop them from falling. What is the actual physical intervention that pulls them back?
The immediate priority is stabilizing the cardiovascular collapse. Essentially, we have to fix the body's plumbing and pressure.
And the sources spend a massive amount of time on fluids here. The strict rule is to administer at least 30 milliliters per kilogram of intravenous crystalloid fluid within the first 3 hours. And there's a neat caveat. They adjust that math for ideal body weight in patients with a higher BMI so they don't overdo it.
But first of all, what is crystalloid fluid? Is that just a fancy medical term for salt water?
Essentially, yes. Crystalloid fluids are sterile solutions of water and precise concentrations of electrolytes, like sodium and chloride, that mimic the body's natural blood plasma.
Okay, so if you take a 100-kilogram person, 30 milliliters per kilo is 3 full liters of salt water. That sounds like a massive amount of liquid to pump directly into someone's veins in just 3 hours. Aren't we basically flooding the engine and risking drowning the patient?
It sounds like a lot, yes. But to understand why we do this, you have to look at what sepsis actually does to the blood vessels at a microscopic level.
When the immune system detects this massive infection, the white blood cells release a flood of inflammatory chemicals called cytokines. And these chemicals cause the blood vessels to widen, which we call vasodilation, and the vessel walls become incredibly leaky.
Leaky? Like a garden hose with a bunch of pinholes in it.
That is a great way to picture it. The fluid that is supposed to be inside the blood vessels literally leaks out into the surrounding tissues. So the overall tank, the circulatory system, is suddenly completely empty.
Oh, wow. So the pressure just drops.
The blood pressure tanks, meaning oxygen-rich blood, isn't reaching the kidneys, the brain, or the liver. So pumping in that 30 milliliters per kilogram of fluid is an emergency stopgap measure to aggressively refill that leaky hose so the vital organs don't die on the spot.
Wait, so the body's own defense mechanism, the inflammation, is actually what empties the tank and kills the organs? That seems like a terrible evolutionary design.
It is an evolutionary mismatch, for sure. Because inflammation is designed to isolate a small local infection, like a cut on your finger.
Right, it gets red and swollen.
Right. It brings extra blood flow and opens the vessels locally so white blood cells can get to the injury. But in sepsis, that local alarm goes systemic. The entire body's vascular system opens up all at once, which is a catastrophic failure.
That is terrifying. But getting back to my earlier worry, pumping in 3 liters of fluid, you said they are filling a leaky hose. How do they know when the tank is full? Like in a busy ER, how do you know the exact second you need to stop the fluids before that salt water backs up and drowns the patient's lungs?
That is the critical challenge. And the guidelines heavily emphasize constant dynamic reassessment. Doctors don't just hang the fluid bag and walk away.
I would hope not.
They are constantly checking to see if the heart can actually handle the volume. They use bedside tools like placing an ultrasound probe directly on the patient's chest to literally look at the heart squeezing in real time.
Oh, that's cool.
And they look at the lungs with the ultrasound to see if fluid lines are starting to build up in the air sacs. If they see any signs of fluid overload, they stop the IV immediately.
Okay, so you've refilled the tank with fluids, but if the hose is still too wide and leaky, there's no pressure to push the blood around. How do they squeeze the pipes back down?
That is where vasopressors come in.
Right.
These are incredibly powerful drugs, like norepinephrine, that essentially command the smooth muscle around the blood vessels to clamp down tight, which forces the blood pressure back up. And if we connect this to the bigger picture, here is where the 2026 guidelines make a massive paradigm-shifting recommendation regarding how these drugs are actually given.
Let's get into this because reading the background on this blew my mind. Traditionally, doctors were terrified to give these vasopressor drugs through a normal IV in the arm. Why was that the rule?
For decades, it was absolute medical dogma that vasopressors could only be given safely through a central line.
Which is exactly.
A central venous catheter is a long, large valve that is surgically placed deep into a major vein in the neck or the chest, right above the heart. The fear was that if these vessel-squeezing drugs leaked out of a standard small 5E in the arm, they would clamp down the local blood supply so severely that it would cause tissue necrosis, meaning the skin and muscle in the arm would die.
Yikes. But placing a central line into someone's neck isn't a quick thing. I mean, that requires a sterile drape, an ultrasound machine, a specialized physician, and most importantly, it takes a lot of time.
Exactly.
And the new guidelines say, do not wait for that. They suggest starting vasopressors peripherally, through a standard arm 5E.
It is revolutionary. It proves that in septic shock, time is the ultimate currency. The data finally proved that letting a patient lie there with dangerously low blood pressure while you spend 30 minutes setting up for a sterile neck procedure is actually far more dangerous and leads to higher mortality than the small risk of a local IV complication in the arm.
Wow. So you're trading a small risk to the arm to save their life.
Yes, we are prioritizing the survival of the brain and the kidneys over the theoretical risk to the arm. It is a profound shift toward pure speed.
Speed and extreme precision, it sounds like. Because even when they are clamping those vessels to get the pressure up, they have an exact target in mind. The goal is to maintain a mean arterial pressure, or MAP, of 65 millimeters of mercury.
Right.
But the 2026 data introduces a really nuanced exception. For patients who are 65 and older, they suggest aiming lower, targeting a MAP of 60 to 65. I really want to understand this. Why are we aiming lower for older adults? Wouldn't we want their pressure to be as robust as possible?
It seems completely counterintuitive, but it relies on a concept known as permissive hypotension. As we age, our cardiovascular systems become less elastic and less tolerant to the aggressive side effects of powerful drugs.
Okay.
Think about what a vasopressor does. It artificially clamps down the body's pipes. This forces the heart to work incredibly hard to push blood against that immense resistance.
Like trying to blow air through a tiny coffee straw instead of a wide tube.
Exactly that. It is physically exhausting for the heart muscle.
Mm-hmm.
If you push an older patient's blood pressure too high with these drugs, the heart has to work so hard against that tiny straw that you drastically increase their risk of triggering severe arrhythmias, like atrial fibrillation, or even causing a heart attack.
Oh, I see.
The new data shows that in older patients, giving just enough pressure to keep the organs alive, that 60 to 65 range, is vastly safer than pushing massive doses of drugs just to hit an arbitrary higher number.
Okay, so we've bought them time, we've fixed the plumbing, we've got the pressure stabilized so the organs are getting oxygen. But the underlying fire, the infection itself, is still raging. We have to transition from physical stabilization to chemical eradication. And the rules around antibiotics in these guidelines are intense.
The timing of the antibiotics is arguably the most fiercely debated and critical element of the entire guideline.
Let's talk about the clock then. For a patient in true septic shock, meaning their blood pressure has collapsed, antibiotics must be given immediately, ideally within 1 hour of recognition.
Right.
But if a patient just has possible sepsis without the shock component, doctors actually have a 3-hour window to rapidly assess if it's truly an infection before giving the drugs. And before they give any antibiotics, they must draw blood cultures. Can you explain what a blood culture actually is and why they are so obsessed with doing it first?
Sure. A blood culture is when the nurse draws a few vials of blood, sends them to the lab, and they're placed in an incubator to see if any bacteria literally grow in the sample over the next few days.
So it's literally farming the bacteria.
Yes, it is how we identify the exact microscopic bug causing the illness. And we have to draw it first because antibiotics are like a biological bomb. The moment they enter the bloodstream, they start wiping out bacteria.
So if you draw the blood after you drop the bomb, the sample might look clean, even if the infection is hiding deep in the tissues somewhere.
Right, you destroy the evidence before you collect it. If you do that, we are flying blind for the rest of the patient's hospital stay, never truly knowing what enemy we are actually fighting.
Okay, but this brings up my biggest question. If sepsis is so deadly and it moves so incredibly fast, why not just use a scorched earth approach from minute one?
Whoa.
I mean, why wait for a culture to grow? Why not just give every single patient the absolute strongest antifungal, multi-drug resistant cocktail immediately, just to be safe? Wipe out everything that could possibly be causing the problem.
That is a very common instinct, but this raises an important question about one of the greatest challenges in modern medicine, which is the collateral damage of antibiotics. It's a concept called antimicrobial stewardship. You see, the human body is heavily reliant on a delicate ecosystem of billions of good bacteria or microbiome, particularly in our gut.
So the scorched earth approach doesn't just kill the bad guys, it destroys the good guys too.
Exactly. If you drop a nuclear broad-spectrum antibiotic bomb on every patient, you completely decimate their microbiome. This leaves them highly vulnerable to secondary opportunistic infections. For example, a severe intestinal infection called C. diff. C. diff bacteria naturally live in the environment, but when your good gut bacteria are wiped out, C. diff takes over, causing severe, sometimes fatal diarrhea and colon damage.
So by trying to save them from sepsis with massive drugs, you accidentally give them a fatal gut infection.
Yes. Furthermore, striking blindly with the strongest drugs drives global antibiotic resistance.
Which is a huge problem.
Massive. If we use our absolute last resort antibiotics on every single patient who walks in the door, the bacteria will rapidly evolve to survive them. Within a few years, we will have nothing left in the arsenal to treat anyone. And frankly, the data shows that obscure fungal infections and rare multi-drug resistant bugs only cause a very small minority of sepsis cases anyway.
Oh, really?
Yes. Exposing everyone to highly toxic drugs causes massive harm, like permanent kidney failure and liver toxicity, for almost zero benefit.
So it's really about being a sniper and not a bomber. And the guidelines actually mandate a strategy called de-escalation. Once the lab grows that blood culture and says, aha, the culprit is E. coli, the doctor is supposed to actively stop the broad-spectrum drugs and switch to a narrow, specific drug that only targets E. coli.
You secure the perimeter with broad coverage initially, but the moment you have the precise intelligence on the enemy, you de-escalate. You put away the heavy artillery and use a targeted strike. This saves the patient's remaining good bacteria and protects the global supply of effective antibiotics.
I notice a huge section in the sources regarding how the antibiotics are physically delivered into the patient's vein too. Does it really matter if you push the fluid through the 5e fast or slow?
It matters immensely, actually, and it was the subject of a massive recent study called the Guideline 3 trial. It focuses on a class of drugs called beta-lactam antibiotics, which are the most common ones we use, like penicillins and cephalosporins. The 2026 guidelines now strongly recommend administering these specific drugs via a slow, prolonged infusion, rather than a quick, say, 20-minute bolus.
Why does the speed of the drip change how the drug works?
It comes down to pharmacodynamics. Beta-lactam antibiotics do not kill bacteria based on how high their peak concentration reaches in the blood. They kill bacteria based on how long the drug concentration stays above a certain lethal threshold.
Oh, interesting.
If you give a quick bolus, the drug level spikes very high, but the kidneys filter it out rapidly, and the level in the blood drops below the lethal threshold. During that dip, the bacteria have time to recover, regroup, and multiply.
Let me see if I have this right. It's like watering a very dry, dying potted plant. If you dump a whole bucket of water on it all at once, most of the water just runs off the hard soil and spills over the sides. The roots don't get much.
Right.
But if you set up a slow drip that continuously soaks into the soil over a few hours, the plant actually absorbs it.
That is a brilliant way to conceptualize it. By using a prolonged, continuous infusion over several hours, you maintain a steady, constant siege against the bacteria in the bloodstream. The BLing-3 trial definitively proved that simply changing the speed of the delivery without even changing the drug or the dose keeps the drug levels consistently therapeutic and significantly improves patient outcomes. It is the ultimate example of working smarter, not harder.
Wow, working smarter, not harder. That really is the underlying theme of this entire massive document. When you zoom out and look at the intricate choreography of modern sepsis care that we've just discussed, it is breathtaking. You have this rapid Formula One pit crew screening patients at the ambulance door. You have the exact weight-adjusted fluid math to refill the leaky plumbing while simultaneously checking the lungs with an ultrasound.
It's incredibly coordinated.
Yeah, and you have the life-saving, rule-breaking shift to peripheral vasopressors to buy precious time, and you have the ticking clock of targeted slow-drip antibiotics protecting the global microbiome.
It is a phenomenal logistical and scientific achievement. But it only works if the system is prepared to execute it flawlessly every single time across every discipline in the hospital.
And you might be wondering, why does this matter to you? You aren't an ICU doctor running a code, but medical emergencies happen to all of us. If you or a parent or a child are ever sitting in an ER with a severe, confusing illness, knowing how this system works completely empowers you.
Absolutely.
You now understand the extreme urgency if a doctor mentions starting vasopressors, and you can ask about peripheral options instead of waiting for a central line. You know the exact reason behind those rapid IV fluids. You know why the nurse is desperately trying to draw blood cultures before they hang that antibiotic bag. You know the language of survival.
Knowledge in those terrifying moments is an incredible shield. It allows you to understand the chaos and advocate effectively when seconds count.
But I want to leave you with one final lingering thought. It's pulled directly from a very brief, almost passing mention at the very beginning of the source text. The guidelines note that sepsis causes new and worsened physical, cognitive, and mental health problems in many survivors.
Yeah, that's a crucial point.
Medicine has engineered this incredible high-speed pit crew to pull you back from the brink of death in the ICU. But because of these amazing advancements, millions more people are surviving that acute shock.
Which means as a society, we're facing a completely new medical landscape.
Exactly. Are healthcare systems prepared for the silent epidemic of post-sepsis syndrome? What happens when a patient survives the ICU but goes home with profound lingering brain fog, severe muscle wasting, and PTSD from the trauma of the interventions?
It's something we really need to figure out.
Ponder that as you go about your day. The battle, it turns out, doesn't end when the IV is finally removed. Surviving sepsis is just day one of a very new, very challenging life.
An incredibly sobering but important point to remember.
Thank you for joining us on this deep dive into the 2026 Surviving Sepsis Guidelines. Keep questioning the dogmas, keep learning the mechanisms behind the medicine, and stay curious. See you next time.